Good afternoon. I'm glad to be back here in George Ben Johnson Auditorium, where I used to attend grand rounds when I was an intern in medicine here in 1981. So we're going to talk today about the aging population and some new initiatives that have been started to make for better healthcare of the aging population. A special emphasis on this group called the baby boom generation, of which I'm one. Any other boomers in the room? A few. Yep. So wanted to talk a bit about how the boomers are impacting our society as well as our health system, and what things at the end we'll talk about what things we can do to counteract some of the problems that we're facing right now, in part as a consequence of the successful aging of our society. So there is now something called an age-friendly health system. Who has heard of age-friendly health system as a concept? I know Bert has. All right, so this is good because I'm going to mostly talk about what makes an age-friendly health system. And since you guys haven't heard about it, this will all be new for you. Oh, okay. There we go. Some people can. Stop there. Okay, good. Thank you. So keep your mind fresh. Here we go. Thank you. How do I go? Maybe yes, maybe no. There we go. Yeah. There. All right. So the folks that put this concept together defined 4 central themes that characterize an age-friendly health system. One is emphasizing for the patient what matters most to the patient and their family. The concept here is that as you get older and closer to the end of life, oftentimes afflicted with multiple chronic conditions, maybe less well than you used to be, priorities change, and you often have to put 2 or more things into essentially relief, one versus the other. Am I going to be treated more aggressively for heart failure at the cost of having worsened renal function? Am I going to take the surgery at the potential risk of my life, loss of function, and so on? All of these competing choices. What matters most to the patient? Second domain, medication management. As you get older and start to accrue chronic conditions, you will wind up oftentimes having more and more medications, and keeping those all straight as you move through healthcare and through life becomes a challenge. Third is mentation. And so in this domain, the issue is recognizing the baseline state of the patient and how functional their brain is. We're notoriously not very good at that. We find patients come into the hospital, we see that they're very confused, but we don't really know what their baseline is, and we're slow to recognize when there are cognitive difficulties that are starting to bubble up in patients who are not yet critically ill. So mentation is the next. And finally is mobility. We'll spend a little time talking about mobility as a factor. Obviously, if you get sick, you become, in many cases, less mobile, but there are a variety of things that can result in lowered mobility without really being very sick. However, lowered mobility has a big impact on your ability to sustain yourself through challenges that make your way in terms of health. So those are the 4 M's. What matters most? Medicines, medication management, mentation, and mobility. And we're gonna hit those 4 or 5 times. By the end of the session, you'll know them for sure. So who put this together? John A. Hartford Foundation, the Institute for Healthcare Improvement, and a couple of other entities got together and came up with this idea, aiming for a platform or a frame into which all organizations could put themselves if they were interested in doing a great job of taking care of older patients. So here we're going to turn and talk a bit about this group of people, the cohort of the baby boomers. These are people who were born between 1946 and 1964, 46 being the end of World War II. People came back from war and started investing their time and energy into making families, and we had lots more babies for a while. So there's this histogram that's changed. On the left, 1960, a much larger number of young people in our society, and as time has passed, a squaring off as the baby boom generation has moved up in years. And so now we have this phenomenon where the proportion of older people in our society relative to the number of younger people has shifted quite a bit, and that has major implications. So this is another graphic to represent that squaring off and the movement of the baby boom generation through the population histogram. I tried to put this talk together with a lot of visuals, so you guys don't have to memorize numbers, but just keep the pictures in your mind. This is the snake eating the elephant, right? So the baby boom is moving through our society like a snake that just ate moving through the society like an elephant that was eaten by a snake. So what are these boomers like? You know, how do you characterize them? Well, it's kind of an interesting group because they're not all the same. There are all kinds of different people in the baby boom generation, all kinds of different races, cultural backgrounds, economic circumstances, different parts of the country people are from, and basically a heterogeneous group, generally pretty healthy for the most part, and relatively affluent compared to years past. Mobile in general. Nuclear families are sort of fragmenting as kids move away, and people are now being left behind in some cases. There's been a gradual improvement in life expectancy from age 65 going forward. So as you get older, you're now starting to expect to live into old age. So you get to be 65, it's pretty likely you're going to get to be 85, maybe 90. And then you have this question of how strong is your social network. So for most people, quite extensive and really very successful social networks. There are some obviously not so successful and relatively isolated. And the priorities are very different between the aged population and the younger population, even within the baby boom group. People who were born in 1946 may have different thoughts and expectations about what life should be like for them compared to people born in 1964. So I'm going to take you through some depressing news about all this. Part of the challenge that's being created by this aging population is that we essentially have an unsustainable and unaffordable cost burden associated with rendering healthcare in the country. And likewise, we have insufficient social supports and related funding to maintain the need, support the needs of this aging population. If you think about community infrastructure, if you really want to have a very successful community for older people, you need great transportation, you need places where people can live, where they can easily get to food, get to social interactions. These kinds of things tend to be more available in many urban areas and less in more less densely populated areas. And then you have the other part of this, which is the family caregiver support systems, which are being sustained now by younger people such as yourselves who may be busy working and raising families of your own, but are being called upon to help out as support systems for an older person who is becoming less well. And we're going to go into a little bit more detail on this in the next little while. Now I'm going to talk to you about the distribution of social supports as a national perspective. There's something called the Area Deprivation Index, which is a validated tool that allows people interested in these subjects to evaluate the resource support systems within communities at a fairly small microscopic level geographically. And this color map, heat map, shows you what that looks like. So if you're in a blue area, you're in the relatively more supported environment. The darker the blue, the better. And if you're in a red area, less supported, the darker the red, the worse. So you can kind of like take a mental snapshot of what that is. And here's Virginia in a little bit more detail. The two green stars are the two hospitals that we've bought, right? So we have this hospital up in New Kent, and we have a hospital in South Hill. And then the circle is, of course, Metro Richmond and down to Petersburg. And what's pretty obvious, those of you who've been around here for a while know this, right? So I live now in Short Pump. I moved out there for the school systems. We adopted a child a couple of years ago, and dark blue, right? So lots of resources, lots of people with money and comfortable lifestyles moved to the east side of Richmond and south of the river, on near South Side and down towards Petersburg, a lot less affluence and a lot less support systems in place. So the message here is that there's a disparity. There are inequities in the extent to which people have support around them in the community where they live. What this comes down to then often is what the family can do. And what we see here is the support ratio. So the blue bars are working age population age 16 to 64 relative to the 85-year-old group. And what the blue bars are doing is they're getting smaller over time. So there are less young people around to either pay taxes or do the work, clean the poopy bottoms and whatever else it is that's required to take care of the older person. And then if you look at the group who really do most of this work, which is women, age 25 to 54, that's the brown bars. And those numbers are also going down. So we have a relative insufficiency of family caregivers as time has gone by from 2000 to 2040. It's getting worse and worse. We're going to have to find a solution to that because somebody's got to clean the poopy bottoms. All right, so now we're gonna take that general view and we're going to add a couple of factors. I told you this is going to be a little nerve-wracking. So we're going to add frailty and comorbidity. Every year I talk to the M1 class about what happens as we age. So unfortunately, we're at our best when we're about 20 or 30, organs fully developed, brains have mostly matured, and we're functional, as functional as we're going to be. Our organs start to gradually, progressively decline in their reserve capacity as time goes by. No matter how healthy you are, there's a decline of varying degrees, but a fairly significant decline by the time you're 85, as much as 40 or 50% of loss of reserve capacity in most of the major organ systems. Fairly disconcerting, still usually sufficient for most people to do okay, unless you put them under a lot of stress, big surgery, big sickness, something of that sort. So generally it's okay. That's the background. The aging body is not the same as a young body. Among those things that age is the musculoskeletal system. There's conversion of muscle to fat. So-called sarcopenia occurs. This is a CT scan on the left, which is a young person, and on the right, which is an older person, and then a cartoon, kind of a depressing cartoon of an older person becoming more hunched and less healthy looking. And so when you add aging lungs, heart, vascular system, and muscles together, you end up not being able to run as fast. So this is best record times for marathons at different ages in life. And what you can see here, I have a pointer? That point? Yeah. There you can see pretty flat across from late 20s up to late 30s, and then starting to climb. The best times, these are trained athletes who, are in as good a shape as you can be at that age, right? So by the time you get to be 80, you're just not going to be able to compete with a 30-year-old running marathons because your body has evolved in a way. Now we add conditions. So if you add conditions to this mix, health problems, right? Heart failure, lung disease, renal disease, actual diagnoses, not just age. You add burden essentially to the body system. And if you take and add those things up in a formal index, like Mary Charlson and colleagues have done, a repeatedly improved index over time, and apply it to the outcomes expected for certain kinds of conditions, in this case, cancer, you see that as you add illness burden, comorbidity, your likelihood of survival with these conditions gets worse. That's not a surprise to anybody. Now, there's one more concept to put into the mix here, which is that of frailty, which is a slightly different problem from comorbidity. So frailty is a syndrome that's been defined by Dr. Freed, who's now up at Columbia. And what she did was she characterized this occurrence that takes place with many older people where they become less vital, less able to compete with challenges and stresses, and defined that syndrome with 5 characteristics: slowness, weakness, weight loss, low activity, and fatigue. And then underneath all that is a substrate of a variety of things. So, oxidative stress, genetic issues that people have in their bodies, inflammatory conditions, metabolic syndromes, and other things of that sort, all contributing to this syndrome of frailty. Frailty, here defined, there are objective measures for each of these 5 criteria. And you can make a score and use that score to predict outcomes. One of the things is slowness, as I mentioned. This is from JAMA. It's a graph of gait speed versus survival. So as you slow down, at different ages, you can see that a slower gait is associated with lower likelihood of survival. So if you just take those curves and at each age point, you can make fairly significant differences in terms of your likelihood of making it for another 5 or 10 years based on how fast you can move or not. That's slowness, and this is quartiles of gait speed as related to outcomes. Again, wanting you to have a visual there, it's quite a significant impact. The gait speed by itself, without knowing why the gait speed is bad, it could be because of arthritis, could be because of a stroke, could be spinal stenosis, could be COPD, heart failure, whatever else it is. And then for those of you who love statistics, the receiver operator curve is a way of representing the effectiveness of a predictive model or a test at determining how likely an outcome is, right? So it's sensitivity on the y-axis and 1 minus specificity on the x-axis, with a perfect test being defined by the lines in red, and a 50-50 guess by the line in the middle, diagonal link up. And you can see the Anesthesiology Society of America predictive model for likelihood of surviving surgery. And then what happens if you add the frailty score to the ASA model. And you can see that there's quite a substantial improvement in the performance of that model as you move towards the upper left corner, which is perfect, from the diagonal line in the middle, by simply adding frailty to the ASA index. So now I'm bringing you back to remind you that the theme we're working on is the 4 M's and how we're going to use the 4 M's to make things better for our older patients in our health system. I'm going to give you 2 more bits of depressing news before we move to the good stuff, which is how do we fix it? Well, it's actually more than 2 more bits, but I'm going to talk about rising trends. So dementia is a very serious problem, right? These are incidence graphs from a variety of different studies at different age groups. So age 65 to 69 on the far left, 85 to 89 on the right. People newly diagnosed at those age points with a condition of dementia, whether it be Alzheimer's disease or some other form of dementia. More important is what the prevalence is. So Australia, because it's got a national health system and essentially collects data on all of the members of their society, we can get an idea of how prevalent dementia is in an industrialized society. So this shows you that if you're, like, say, 80 to 84 in Australia, the prevalence that, what percentage of that population in that group is going to have dementia, maybe 13%. Got up to 90 to 94, it's more like 35%. So as we succeed in extending life and having more people around who are old, we're going to have a much more significant percentage of people that are afflicted with dementia. And dementia, as we all know, really creates all kinds of stresses and strains on the healthcare system, as well as the family structure and the economy. So this is what it looks like in the economy. We're in very bad shape here. The Medicare Trust Fund, which pays for hospitalization, post-hospital nursing facilities, home health care, skilled home health care, and hospice, is based on a financial instrument which was created in 1965 called the Medicare Part A Trust Fund, which is a self-renewing source of funding that is sustained by the government, and it's balanced out by how much we withdraw from it to pay for healthcare in each year. And the trust fund, based on the most recent predictions, is expected to go into deficit spending in about 2 or 3 years from now. And these are billions of dollars, to be $240 billion in deficit by 2029, which is what, 6 years from now, right? So that's bad, because we're either going to have to print money or raise taxes, or we could just start cutting services. And this is another way of showing that same thing graphically, which is essentially we're almost at the limit of what we can expect in terms of the Medicare model for payment and supporting the geriatric population. Now, something that's important to me, and I think you all should know, if you haven't already thought this through, is that as we think about the population, the aging population, the resource utilization curve is not even across all, right? And that makes perfect sense. This is typical of any group. So what you can see here is a graph from ages ago, 2013, but this same thing has been shown over and over again. I just happen to have this one conveniently available. So in the green box is the people who are using the 50% who use very little resources, right? Use 4% of all of the formal payments in healthcare. They're the healthy people in our side. 50%, the top 10%, whether they be critically ill or severely chronically ill with recurrent hospitalizations, use something like 60% of the resources in any given year. So if you really want to curtail your spending habits in the next 4 to 5 years, you have to do something about that top 10%. We've not been intentional about getting a handle on that. We tend to treat patients episodically in one place or another, move them to another place, and they recycle and come back. And we end up paying the bill because we don't have a good system in place for maintaining continuity and preventing reoccurrent illnesses, or with helping people understand that they're coming to the end of the line and making a change in philosophy, as some will need to do. And then to sort of finalize the economic woes, the Social Security budget is also going to go into receivership in about another decade and change. So we have a really significant problem, both in healthcare and social support financing across the span of governmentally funded resources for geriatric care. At the same time, as all of that bad stuff is going on, we're spending a boatload of money, but we're not spending it for the most part on supportive care in the community. And, you know, if you compare our spending to other industrialized countries across the world, we're doing a lot less to provide supportive care for our elderly population at the present time. And if you happen to be from a family that's dealing with these issues, you will know that the median income for a Medicare beneficiary is dwarfed by the expected annual costs of most of these forms of formal services that you can purchase to provide for people. So it's really not affordable to look at nursing facility care or semi-private nursing facility care, daily home health care aides. For most people in our society, can't afford it. The Medicaid program provides much better support, but is only available to people who are essentially destitute and is not equal in its way of handling these things across the 50 states. This is a graph that or a map that shows you, the states that have really invested in home and community-based care, as contrasted with a dark blue is places that have put it 75% or more of their long-term care services and supports are rendered in the home as opposed to institutional care. Majority of the country is in the middle, 50%, and then there are states down toward the southeast, neighbor states of ours, where much more of the long-term care services and supports are in the form of nursing homes. So just to say that we're spending a lot on healthcare, but we're not spending a lot on long-term care services and supports, and particularly not in an even-handed manner. Yet, we are essentially bankrupting the states who can't afford to pay for their Medicaid programs. And finally, I think this is just pretty close to the end of the depressing news, that we've had a little pandemic thing going on. And we don't have nearly as many workers as we used to have. You see the orange and red bars, they represent workers available to help out with assisted living and nursing facility care. So not nearly as many as we need and as we used to have. So what does it look like if you're a patient? You are moving from one care setting to another care setting, from one doctor's office to another doctor's office, from hospital to home, from hospital to nursing home to home, and you have these different providers taking care of you. We pass you back and forth between folks, and there's not a really great system for making sure that there's a good understanding of where you came from and where you're going as you move through. So we make a lot of transition errors. This is just a representation of the numbers of individual doctors that Medicare beneficiaries see. Many see dozens of doctors in the course of a year. The doctors don't necessarily all communicate with each other. And this is a representation of the mix of different places where people get care, as I had just mentioned, with the hospital being the most intensive at the apex there. And this is from a hospital medicine group that was doing some performance improvement related to congestive heart failure, looking for root causes with this fishbone diagram of problems associated with congestive heart failure management, medication management as people moved in and out of the hospital. So now I'm at the end of the depressing. I'm just going to remind you of all the depressing stuff I've told you. We do have this really large cohort of people moving up age-wise in our society. They're actually quite healthy and interesting and challenging and resourceful and great. But some of them are not doing well. And there's quite a bit of disparity within that group in terms of the way that their life has transpired and how healthy they are. These things all have big implications for financing of care and social supports. And we've talked a little bit about the way our system is not well organized to do a good job of taking care of these people so that they maintain stability and a reasonable path and a plan of care over time. So in the background, we have this sort of burgeoning problem with dementia and a lack of reliable social support. So we've now been through a statement of the problem. So I'm going to move from that to talking about what we are doing and what we can do to make things better, which is, I think, a much more positive thing to talk about. So back to the 4 M's, reminding what matters most: mobility, medication management, and mentation as the 4 themes that we need to remember from today. What we want in a healthcare system. So what we are doing here at VCU Health, and I'm glad that Alan Dow is here in the audience because he's been instrumental in putting together the IPEC program, the program for interprofessional education. One of the things we're doing. And Bert Waters, who's here to comment, is going to talk a little bit about the Geriatric Education Center and the Geriatric Workforce Enhancement Program. But we also have a bunch of other sort of core initiatives. We have here at the VCU School of Medicine a 4-year curriculum aimed at teaching our students to be more knowledgeable about older individuals and better prepared to care for them in our society. Most schools don't have this, so we're kind of unique. Not exactly the only school, but one of a relatively small percent that have this sort of program. We've done a lot of work with our residency programs, internal medicine, orthopedics, anesthesiology, the IM preliminary program particularly, to help train people in the company of geriatricians and others who are particularly interested in this subdomain of topics. We have a really good fellowship in now a 4-year internal medicine geriatrics track within our residency program. We have an inpatient consult and co-management service that brings learners into the care of older patients and brings geriatricians into close partnership with surgeons, neurologists, and others in the hospital. I've mentioned Alan's interprofessional education program, and I've mentioned Bert's work with the GWEP. Bert and Christian have done quite a bit of work as well with funding from the CARES Act and now funding from the Virginia Department of Health to do educational work related to nursing home care and to prepare the staff of the nursing homes to do a better job. And then Pam Parsons, who's been part of the geriatrics program for years now and is in the School of Nursing, has a thing called the Richmond Health and Wellness Program, where they're taking learners into congregate living settings and teaching them a little bit about geriatric assessment and care coordination. And then we're doing work on system improvement. And we're doing okay here because I'm going to be done in about 5 minutes. We'll have time for a little bit of discussion. So you've heard some of this before if you've been to our talks. There's a little bit of drum beating. We've been moving in the direction of having a systematic and continuous approach to the care of older people across settings and over time. On the left, we are moving away from what we have historically referred to as a house of brands. So a lot of expert pockets working independently in sort of a silo manner, oftentimes without shared records, without good interconnectivity, towards a future state, a branded house, VCU Health. So we're all recognizing ourselves as part of an organization that is working collectively and in a coordinated manner to do a better job of taking care of these older individuals at the moment when they are in crisis and over time, pre and post crisis. This is a picture of the building where the Continuum Integration Center has been organized. That's a group of folks whose primary focus is to consolidate the efforts or perform sort of air traffic control function to maintain some order in the way that we take resources to the community and distribute them towards patients that are served by VCU Health. There's a list of some of those programs here on the right. I'm not going to read them all to you, but mention among them, we're going to all of the nursing homes in town where VCU Health sends patients and taking care of them with VCU Health docs and nurse practitioners who are writing notes in the nursing home record and in Epic and connecting the patients back. We have created our own home health agency in hospice. They have started operations. They have Medicare approval for work in Virginia and are working on their private contracts. They have a fairly active caseload. I was in the hospice interdisciplinary team meeting this morning and reviewing cases with them. So these are the offices over on off of Glenside and Broad, about 4 or 5 miles to the west of here. And the phone number for our home health agency and hospice, the VCU Health Home Health Agency and Hospice, which we have created in partnership with a large private not-for-profit company called Beata. But make sure that you remember these are VCU Health Home Health Agency and Hospice programs, not Beata programs. Those are our partners at Beata. We have in geriatrics been operating out of 2116 West Laburnum Avenue, a place called the COM, the Center for Advanced Health Management. We've been operating clinics and the home-based primary care program. It's the home base for the nursing facility attending service that I mentioned before that Christian leads and administrative support. We have physician leads who are helping us move all of these programs along. Christian for the nursing facility attending service, Brittany Craven for our clinics, Sarah Hobgood for the inpatient consult service. She happens also to be an associate dean for medical education. The home-based primary care program, which I started back in '84 under Katie Brennan now. Julia Siegel-Breton, helping with hospital at home along with one of the hospitalists and serving as the medical director over at the center, at the KIC, the Continuum Integration Center. 2 physicians from PM&R who are helping us find the right place for patients to go when they're ready to leave the hospital. We've been working with utilization management, Taruna Aurora, and we have, as I mentioned, in our hospice, we have Rachel Selby-Pensack serving as the interim medical director and also doing something called Preference Bridge, which is helping people who are probably suitable for hospice but are struggling with that decision to find their way through. And then we have an administrative team, because you can't do these kinds of good work without having people helping to coordinate. A lot of meetings with lawyers, businessmen, and other people to put these programs in place and to make sure that they're running smoothly, gather data to see if they're doing what you want them to do, and helping correct if they aren't. So this is the administrative team that's hanging out over there at the KIC. So I'm basically done with what I wanted to say. So it's good to reprise and remind everybody what we talked about. We talked about the baby boom cohort and population aging, its implications on public policy and finance, which are fairly scary. Some things that we need to do better in terms of the way we deliver healthcare for people with significant chronic health problems. Some of the educational works and system redesign that we're in progress of doing, and taking us back to the age-friendly health system that we want to become, paying attention to what matters most to the older patient and their family, to their mobility, to their medication coordination and management, and an understanding of cognitive abilities and loss of abilities. And so finally, I'm going to close off with Ted Lasso. Those of you who haven't had the chance, it's really quite entertaining and worth the watch. And ask if we have any questions or comments.
Thank you all. Thank you, Dr. Boling. We're going to invite Dr. Waters up here just to talk about the Geriatric Education Center and the Geriatric Workforce Enhancement Program. Dr. Waters.
Yep. First off, when I first heard of Peter's presentation, and it was the Weathering Boomers, I wanted to weather the boomers. I wanted to mention to everybody, this is really important because I'm a gerontologist who dangerously dabbles in geriatrics, and Peter's a geriatrician who dangerously dabbles in gerontology. Baby boomers are very heterogeneous. The only thing that Peter and I have in common, we're both baby boomers, are that the years that we were born, there were 4 million babies or more born. That dropped after 1964. From 1965 to 1989, less than 4 million babies were born in the US. And then it picked up again, so it's been back and forth in that range. In 2014, it dropped again too. And then just this last year, over 4 million babies were born. So we do have that similarity, but the cohort is so different, and there's no real cutoff with cohorts. You have to be really careful when you talk about Generation X, Generation Z, because you have to think about how people are unique, and to homogenize a group of people is really not what we want to do in gerontology. So I always try to move my students away from the term baby boomer because there are so many differences. And there are also chronological and physiological differences. So I grew up in Northside, and a couple of blocks from me, there were some kids that lived in Washington Park. And when I was growing up, those kids now are in their 60s. I'm in my 60s, but yet we're completely different physiologically because we've had different lives, and social determinants of health and health inequity really did determine their health. And I have friends that are in their early 60s, and I look at them who are, most of my African-American friends, 3 or 4 of my close friends have had a lot of health issues over the last few years. And a couple of them even went to college and they still have health issues. So there's really a lot of interplay with social determinants of health. And one of the things we do at the Geriatrics Workforce Enhancement Program is we really do focus on social determinants of health. And one of our projects, we've partnered with the Richmond Health and Wellness Program, and now the Richmond Health and Wellness Program is has received a designation as one of the few places in the state that are age-friendly through the 4 M's. And I wish Pam Parsons were here because it really did change their practice. When you think about the 4 M's, it's so important because they are all intertwined, and not many people think about health with what matters most as being the center. We found that for working with older adults, it's really important to have an interprofessional team. And that's not how we operate in the US. We just don't have many interprofessional teams. The program for all-inclusive care of the elderly, the PACE program, is designed to be interprofessional, and it's been very effective. The Geriatric Education Center has been at VCU since 1986. It was one of the first 16 geriatric education centers. Currently, we have 48 geriatric work enhancement programs, GWEPs, across the country. That's not enough. And each of the GWEPs are funded, it's about $4 million over 5 years. And it's a 5-year grant cycle. And we've had a GEC and a GWEP since 1986. And luckily, we've had Peter Boling here since 1981, because our university, the medical education at our university, both undergraduate and graduate, is excellent for geriatrics education. The School of Nursing used to just did not have geriatrics in their education. The faculty told me that they would have one slide at the end of the semester that focused on aging adults. And so now they've incorporated aging throughout life course development throughout their curriculum. And we're also seeing other departments addressing curriculum and changing curriculum based on the needs of the older adult population. And that's why we're here. We're located in the College of Health Professions, but we're actually, again, we're 5 universities. We're VCU, Virginia Tech, UVA, George Mason, and Eastern Virginia Medical School, and also Senior Navigator, Virginia Navigator. That's the other major partner that we have. I don't know what else to say other than I'm so glad that Peter's here. So.
Thank you. Appreciate it. We'll start with some questions maybe from the audience. Anybody online? Yes, Dr. Dow. Go ahead.
Try to get a sense of the impact on a lot of excess deaths for COVID and things like that. So what are you seeing? Are you seeing any sense that the pandemic is extending for one way or another? All of the time.
I'll take
You want to repeat the question?
Yeah.
Just briefly.
Okay, yeah, so Alan was asking about the effects of the pandemic on the health of the population and the ways that the pandemic has shaped the needs of the population. As I had mentioned, that we have a workforce shortage, but I would say it's almost too early to say. You know, we're all aware of long COVID survivors, and what's a little bit harder to compute is the global sort of effect of the isolation that's taken place and the disconnectedness that has occurred in our society as people have been afraid to go out and you know, all of those things. So I think it's something we're going to all come to better understand in another decade or so as we start to get more data and see the result. A lot less flu. People are not seeing other people that they're wearing masks. So, you know, we'll have less influenza illness, but it's a very complicated new factor in the equation for me. Don't have an answer though. Welcome other thoughts if there are people that think they have a good answer. Yeah.
Just in terms of nursing home care, want everybody to recognize that we have, at the start of the pandemic, 1.6 million US citizens in long-term care facilities in the United States. If you look at the data, almost 1 million, so at least 2/3, 66 to 70%, got COVID in the last 2.5 years. Of those, we lost 250, 300,000 folks. So when you look at long-term care in the United States, the cohort there, it looks different today than it did 2.5 years ago. And the question there is, did we lose those that were very frail to begin with in the spring of 2020? We lost a lot of people who may have otherwise lived another year or two. So And compounding that is the increased incidence of dementia with behaviors, depression, mental health challenges, and decreased staff support in long-term care. Dr. Boling showed a slide where the workforce is still only at about 65% of where we were prior to the pandemic in nursing home settings. So I think the impact of COVID for older adults somewhat depends on the care setting. And we have not seen clinical long COVID in nursing homes as much for that patient population. It's the support structure around them and their characteristics that are slightly different. Any other questions in the audience or online?
Can you see the on?
Let's see what we got online. We got a question here from Dr. Meyer. Are there centers for healthcare and Medicaid sufficiently supporting providers to have a dedicated conversations on goals of care in the same way that we have in the yearly well visits? Perhaps certain ICD-10 codes could trigger coverage for visits to discuss goals of care. Any comments?
Yeah, there are codes, in fact, and you should use them. I have started to use them. It's 99495 and 99496, I think. And so what you have to do is you have to make it a priority and make time. You know, you're running like so crazy all day long, trying to be as efficient as possible. The patient comes to you with their 5 or 6 problems and whatever else it is, and stopping to take a step back and talk about goals of care and those sorts of things is oftentimes difficult to squeeze in. So it always gets pushed off to the next visit or next visit. You can schedule people to come in for that, or you can intentionally make time to make it part of the conversation. It's hard to do. It's a habit that we haven't really encouraged, and it's a habit that should be encouraged not just among those who do palliative care, but also primary care and subspecialists, because many of the patients that are dying of advanced chronic illnesses are seeing their subspecialists regularly, but oftentimes are mostly spending their time on the topic of not dying and not feeling as bad as they do right now. And stepping back and talking about the inevitability of dying, which is certain for all of us, but more certain sooner if you're seriously ill, just doesn't get to the table quite frequently. So yeah, there are codes, there are billing codes. We should use them.
Rachel has a comment online.
Yeah, I was just going to add to what Peter said, and this might help with the question that last came up. But the Preference Bridge Clinic is also open to anyone over the age of 18, regardless of their health status, and providers who even mean well during their own clinics, right? Sometimes you guys are dealing with a laundry list of chronic illnesses or acute issues, and you know that time needs to be spent discussing advanced care planning and goals of care, but there's just not time in a clinic. Please feel free to refer anyone over the age of 18 to the Preference Bridge Clinic, and I will be happy to meet with them.
Yeah.
This is more for Rachel. I always say your last name wrong. I refer to you often. How do you sort of, for the patient to understand what you're going to offer? Sometimes struggle with trying to explain what's going to happen at Preference Bridge Clinic. How do you sort of that set up so that they get the most out of it?
Rachel, were you able to hear that?
I don't know who asked it, and I'm not exactly sure I heard the
So,
whole thing.
It was one of our advanced heart failure cardiologists was asking about when referring to the Preference Bridge Clinic, what should patients expect to be doing when they get involved with the Preference Bridge Clinic? How is it presented to them, and what goes on?
Yeah, and so how I would when you're presenting it to folks that you're meeting with, how I would present it is that knowing what their wishes and goals are about their healthcare and function is something that's important to us at VCU because we want to provide high quality care. And some people like to discuss that with providers and view it as something called advanced care planning. When I meet with patients, I don't just focus on the things we tend to think about in terms of code status and whether or not someone would be on a ventilator or want feeding tubes or do dialysis. We do get to those topics, but it's not until I ask them kind of basic questions about whether or not they have had experience with family members or friends, for instance, who were ill, what their understanding is about their own healthcare status, what's most important to them in terms of life and function, whether they value quality or quantity of life. And I have a whole list of things we talk about. I also let patients know that it may not be things they ever thought about before in terms of the questions I asked, and that's okay because there are no right or wrong answers. After my visit with patients, I do document these notes in two ways. One as a progress note, and also when you go in Epic and you go under a patient's name and on that left-hand side where it says code status, you will find all my notes if you hover there, whether if someone's had advanced care planning conversations. And then if someone wants to then put together a written advance directive, I provide them with the Virginia document and we give verbal and written instructions on how to do that. So they're getting a visit with me and then a follow-up letter, and then the notes are sent to not only the referring provider, but the physicians that are most involved in their care. And my hope is that as a health system, that once we know what someone's healthcare preferences are, we can better streamline the care we give them. I hope that answered your question.
Yeah, thank you.
Thank you so much. Want to thank our speakers. We are at the top of the hour, so thank you all for joining us today. Thank you, Dr. Boling, Dr. Waters. We appreciate it, and thanks for everybody online. Please let us know if you have any feedback or comments. Thanks for your time. This concludes Grand Rounds.